דוקטור רובין סטון הינה חוקרת בעלת שם בינלאומי בתחומי מדיניות בזקנה ובסיעוד. היא מכהנת מאז שנת 1976 בתפקידים בכירים בתחומי המחקר והמדיניות בממשל ובמגזר הפרטי והשלישי בארצות הברית. בממשל קלינטון כיהנה דוקטור סטון כסגנית משנה לשר לענייני מוגבלות, הזדקנות ומדיניות סיעוד. במסגרת זו היא הובילה מדיניות לאומית להתאמתם של שירותים לאוכלוסיות המזדקנות. דוקטור סטון מנהלת כיום כמנכ"לית וכסגנית נשיאת מכון המחקר היישומי Leading Age, והיא חברה באגודת הגאונטולוגים בארצות הברית, באקדמיה הלאומית לביטוח סוציאלי ובאקדמיה הלאומית לרפואה. פעילותה המגוונת, המשלבת ידע מחקרי ויישומי מהשטח וניסיונה רב עם רשויות הממשל האמריקאיות, הפכו את דוקטור סטון למרצה וליועצת מבוקשת ברחבי העולם. הרצאתה של דוקטור סטון תעסוק בנושאי הזדקנות מוצלחת בקהילה, מעבר בין עולמות הפרקטיקה, המדיניות והמחקר. והיא תכלול הצגה של אסטרטגיות מבוססות ראיות שהוכחו כמסייעות להשגת הזדקנות מוצלחת והדגשת החשיבות של שימוש בגישה ממוקדת לקוח לעיצוב ותכנון שירותים לזקנים. I'm honored, Dr. Stone, to have you with us today and to learn from your experience and your insights about successful aging. Dr. Stone, please.
Shalom. I have to start by telling Rafi that you're a very hard act to follow. I also have to tell all of you that 60-some years ago, I bought a lot of trees in Baltimore, Maryland, which is where I'm from. And I see a lot of those trees today. So I remember every single Sunday when I went to Sunday school putting my money into the Jewish National Fund to plant those trees. And, you know, as a little kid, you never realized you're going to have any effect on anything. So it's pretty amazing. This is my second time in Israel, but I'm always just amazed at this country and what you have all done. And I will say that I think we have a lot to learn about what you have created. It's almost humbling for me to stand here and talk about aging and aging services because in many ways you are way ahead of the United States. So what I'm going to try to do today is to give you just a little bit of a sense of my career. I actually started in this field when I was 26 years old. And now I'm almost 67. So I've literally been in this field for 40 years, extremely committed to this because I had really, really close relationship with my grandparents. And they made the difference in my life when I was a little kid and never ever thought of any other profession. So I'm assuming most of you guys are in this business as well, and I would never want to work with any other population, and now I'm it. That's really what is so amazing. So just to tell you a little bit about myself, I actually started in the early 70s, mid-70s in Baltimore running a meals program. And I never forgot my roots, even though I have gone through a number of different occupations. In the later 70s, I worked at AARP, which was then about 12 million members. And now there are millions and millions of members in AARP, both in the United States and throughout the world. Then I went and worked in the US Department of Health and Human Services. I became a researcher at the Agency for Healthcare Research and Quality. And in 1990, I worked on the first Comprehensive Healthcare Reform Commission for the United States. By the way, we have yet to achieve total healthcare reform. You all are way ahead of us in that one. In '92, I worked on the second healthcare reform task force, the Clinton Task Force, and that actually got me into the U.S. Department of Health and Human Services as a political appointee for the Clintons. I was both the Deputy Assistant Secretary for Aging, Disability, and Long-Term Care Policy, and then was the Assistant Secretary in the U.S. government for a number of years. Following a very short stint in New York, I came to Leading Age, and I have been there ever since. For those of you who don't know Leading Age, we are a national organization of about 6,000 aging services providers, and we represent the entire spectrum from nursing home, assisted living, home care, adult daycare, home and community-based services, low-income senior housing. We really do it all. All of our organizations that are members of our association are nonprofits, very mission-driven, and committed to making sure that we have successful aging in the United States. And I think the thing that makes me most unique and the message that I want to send to you today is that there's real need for us to be doing the kind of evidence-based work that this organization that is sponsoring this conference does in terms of being an incubator, being a natural laboratory for learning about what works and then putting it into practice. That has been my goal for as long as I have been working in aging. I have a PhD in public health. I'm a researcher. I've also spent a lot of time doing policy work. But bridging those worlds of research, policy, and practice are essential. That's why Eshel is so important to Israel today, because this is the natural laboratory activity that gets you moving in the right path and where you can figure out what the future will be in services. So let me talk a little bit about what I've learned about successful aging in community over the past 40 years. First is living in community in a place called home. That can be anywhere. That can be in an institution. One of the things that we have realized in the United States is that we set up a terrible, terrible dichotomy between living in community and living in a residential setting. And fortunately now we have shifted that paradigm to thinking about home being wherever the person is and making sure that those environments, whether it's an individual home, whether it's a group setting, whether it's a nursing home, these are all places that are home for individuals. This is places where they live and where they thrive. And we should not be setting artificial barriers between those settings, but making sure that they are all places where people live as independently, as autonomously, and with as much choice as possible. And that truthfully can happen anywhere. I see it every day in our members, because many of our organizations are nursing homes that have converted into household models that are truly homes for individuals living there. So if there's one message I can send is that home can be anywhere. And sometimes living in one's own home is not the right place to be. Functioning and re-enablement are key. As you just saw, Rafi is a perfect example of why function is so important. And the potential, the manifestation of function, no matter where we are. You know, one of the strongest evidence-based programs in the world is Tai Chi. If you want to look at an evidence base, Tai Chi has effects on Parkinson's, it has effects on overall mobility, it has effects on sleep. It is a phenomenal cheap way of addressing enablement and re-enablement in our population. And I would suggest that we all ought to be out there on the grass doing Tai Chi right now, because it is an amazing, amazing intervention that works for everyone. In addition, we have to think about systems that are person-centered and person-directed. Just thinking about Rafi as an example, he has built a world around his disability that has enabled him to live independently and autonomously with a lot of choice. Every single individual is going to have different needs. And we need to think about how we design systems that are truly person-centered and that are also person-directed. Because nobody's going to tell you what your goals are. You are the only person that will know those. In addition to that, we have to think about the whole world of where an older person lives. And now, of course, when I used to be 26, now I'm 67 and I'm understanding it myself. I've just found arthritis in my hands, arthritis in my knees. And for me, it's my health, social, and environmental fit that is so important. All of these dimensions are key for us in terms of thinking about healthy, successful aging. It's not enough to think about medical services. It's not enough to think about social services. It's not enough to think about our environment. We have to put them all together. They are all essential for us to achieve successful aging for as long as possible in a place that we call home. And that is why, and I've been told that this is sort of an unusual crowd because we have many, many different kinds of folks from many different walks of life here. Every single one of those dimensions is essential for us. If we don't deal with environment, if we don't deal with the social, and at some point if we don't deal with the medical, we cannot achieve our goals. But we cannot do it without all three of those pieces. They have to come together. And finally, I think what I have learned, and again, Rafi is such a perfect example, we have to focus on our assets, not just our decline and our disability, because we keep our assets forever. And, you know, I have earned every single one of my wrinkles, and I never want them to go away, because those are my assets. That's my wisdom that I have learned over the years. So why is translating research into practice and policy so important? Well, at least in the US, stories are great. And particularly our legislature, our Congress, they love our stories. I call them the Queen for the Day stories. We always pull out the story that's going to rip your heart apart. But at the same time, hard evidence is really essential. And we've got to begin to bring those together. We have to bridge the language barriers between storytelling and data. They are not enemies of each other. They actually go together. And an evidence base provides clarity of concepts, and then we help to translate our findings into real-world activity, and that is why organizations like Eshel are so important. Because we're taking what we learn in natural laboratories and we're putting them into the real world. And there's something very, very different about studying something and then actually putting it into practice. We have to ask the question, so what, right? We're not living in a world of infinite resources. We have to make choices. I met yesterday with the folks at JDC, and we talked about a 5-year strategic plan. And in those plans, we have to make choices between where we're going to invest and how we are going to use limited resources. So that so what question becomes essential. And the evidence base helps us to make that decision. So why should we invest in Tai Chi? Well, it's a fabulous thing to do. But as I said before, if you look at the randomized controlled trials, it's one of the strongest activities on the face of this earth in terms of outcomes. And so why not invest in those kinds of activities rather than what I say is just pulling something out of your ear? How do we implement? How do we actually take something and put it into practice? The only way we can actually do that and know that we're going to be successful is if we have an evidence base behind it. There are ways to do things that work, and there are ways to do things that don't work. And I always tell the members of my association that when you do things that don't work, you've just wasted a whole lot of energy, a whole lot of resources, and you've probably set people back at least 20 paces. So the evidence base is essential for us to understand how do we actually implement in the right way. And then finally, how do we sustain something, right? How many times have you worked on a program that then fell flat on its face? Or it lost its funding and it went bye-bye? As we develop an evidence base, we begin to understand what it takes to sustain over time, and that is really what is essential for all of us. Our programs cannot live by hand and mouth. We have to have ways of keeping them going. And we have to understand the costs and benefits, and that is another piece of why an evidence base is so essential. If we lived in a world of infinite resources, it would be very different, but we don't. And so we have to really focus on where the evidence, both the quantitative and the qualitative evidence, takes us. I'm going to very quickly go through 3 examples of what we've done in the United States, and I know you all have examples that are very similar. But what is really key here is that because of my position in being a researcher and as well being a policy person who also works with a lot of practice folks, we've actually been able to take some of these programs and made them sustainable over long periods of time. And I'm hoping that, some of these examples will ring true for you here as well, because I know that you've got a learning environment and you've got these natural laboratories that are just phenomenal. You don't know how lucky you are to have something like the JDC and Eshel. Very few places in the world actually think about creating natural laboratories and then putting them into action. So cash and counseling. This was a program that we looked at in the early 90s. We had home and community-based services. We were moving people out of nursing homes since the late 70s, early 80s in the United States. And there has been and continues to be a significant attempt in the US to rebalance away from the nursing home dominance that began in the early 60s in the United States. And today, to be honest with you, we have a lot more emphasis and people living in community in their own homes and in other types of residential settings. Our nursing home census has declined substantially. But in the early 90s, we were interested in looking at the international experience with consumer-directed care. What happens if we actually turn over the resource to individuals and let them make choices about how they use the dollars, the resources, and purchase their own aides, their own caregivers, and their own social services and supports. So we looked at a number of the Nordic countries, and we looked at a lot of the research that had been conducted in Germany. And we asked ourselves, can we apply this in the United States? I happened to be the Deputy Assistant Secretary in the HHS at that time. And we worked together with a very large foundation, Robert Wood Johnson Foundation in the US. And we developed a public-private partnership where we actually conducted a 3-state, multi-year, randomized controlled trial of cashing out benefits for elderly as well as younger people with disabilities. And we engaged in a very rigorous evaluation that was done by a large research group in the US called Mathematical Policy Research. This has rarely been done in the US. Most of the time we have had small studies that have supported programs, but we really wanted to test this because we had a lot of people who told us, if you give a family cash, they're going to drink themselves to death, or the families are going to buy all kinds of things that they need, and none of your services are going to go to older adults. And so we wanted to test and make sure with an evidence that we could actually move towards a consumer-directed model without jeopardizing quality and without a lot of abuse on the part of families. Well, needless to say, the evidence was very strong that not only was there not a jeopardizing of quality, but actually quality, and particularly quality of life, improved for those elders and the families who received the cash and were able to make their own choices around how they purchased services and who provided the services. And because of this, cash and counseling has now been adopted in almost all states throughout the United States. Most of our service programs in the US that focus on home and community-based services have at least a cash option. Now, there are many folks who choose to have an agency-directed program, particularly those with a lot of cognitive impairment, where they don't have a family there to actually help with negotiating how you make these choices. But interestingly enough, even folks with cognitive impairment, where there are programs that actually can help them and their fictive kin to make some of these choices, they actually opt for consumer direction. So it's not without its problems. We certainly struggle with how we monitor quality, but at the end of the day, we're able to allow our services to go further because the cash can be used in much more of a flexible manner than agency-directed services, and we also don't have the kind of overhead that you have when you're only going through an agency. So this is an example of a major randomized controlled trial that we invested in over time so that we could not only give voice to consumer direction, but we could also tell our legislators that there was not going to be any harm. And this is why the evidence base is so essential. If I move to the next example, this was a large national program that my organization ran about 15 years ago. Most of you don't know me. If there's anybody in the audience that does, I have been on a bully pulpit for the past 30 years to improve the jobs of the frontline caregivers in the United States. These are the folks that provide almost all of the formal care in the US. They are our frontline aides who work in nursing homes, who work in home care, who work in assisted living, who work across our continuum, who get paid very poorly, who get very little training, and we need to up the ante in terms of supporting that workforce. So instead of just saying, you know, we're going to let this go, we decided that we were going to actually invest. And again, a combination of a number of foundations and the private sector put money together, and we had about $18 million over a 4-year period to invest in a major demonstration and evaluation of what does it take to create better jobs and produce better care in the United States. How do we recruit and how do we retain a quality workforce from the front line all the way to the C-suite? But by the way, we started with the front line and not our CEOs. Because if we can't get the front line right, the rest of our system completely falls apart. And because of the research that we have engaged in better jobs, better care, we have now influenced quite a few states, as well as the federal government, to actually start to put money into training, education, and ongoing support of moving these jobs from what I call accidental to valued professions. We focused on direct care workers across all settings. We had 5 state demonstrations with multi-coalitions that really worked on looking at how we would develop both better policy and better practice. We had a lot of rural-urban diversity, and we had a very strong technical assistance component to this demonstration. So what did we find? The major findings is even a small increase in compensation improves recruitment and retention. In the US, that means even an increase of $1 an hour. The second thing that was so key for us is that supervision is essential. So if you have a system where you are letting folks go willy-nilly out into the community without any kind of supervision, your program is going to fall apart. And we have now invested significant amounts of resources in supervisor training, whether it's folks in nursing homes or whether it's people who are supervising folks who go out into the community. They need to understand how you manage people. We also figured out something, that consistent assignment is really key. So if you have an aide that's going into somebody's home and doesn't stick with that person, you're going to get much worse outcomes. So thinking about how you design consistent assignment in your programs is going to be really important. And finally, career ladders, career mobility is essential. It doesn't mean that everybody has to move from an aide to a nurse. It means that they might become a dementia specialist, or they might become a medication aide, or they might become a social worker, or they might become a manager of an entire team. But thinking about how you develop career ladders and career lattices for individuals is essential. So let me tell you our final example of what we have done in terms of taking research and turning it into policy and practice. Over the years, we realized something in the US, and that is where people live is just as important as the services and the supports that they get. Again, going back to this notion that it's the environment, it's your social world, and it's your medical world. And they all have to come together as we support successful aging anywhere. We also recognize something, and I come out of a public health background, so for me, this is really important. Public health is not medical health. It is population health. It is the intersection of all the things that matter, that determine the quality of life of an individual and of a community. And housing is one of those things that is really, really important. In fact, I would argue that housing and services and supports are really equal. They have to be equal partners in us thinking about how we're going to create successful environments for people to age in. What we have been doing in the United States is experimenting a lot with housing as a platform for actually helping us to link services, coordinating services, and bringing prevention services as well. Truly what Yoshi called an integrated model. But it's an integrated model that begins with where people live. It's not an integrated model that begins with the medical system. Medical system is a part of integration. But to be quite honest with you, it's the last place that you want to be. And so most of our efforts, and quite honestly, we have finally gotten the federal government in the US, and hopefully we're going to keep this going. I'm not sure, we're a little worried about it. But we have substantial investment in thinking about how we create value and quality through integration of services that starts in the community, that avoids at all costs hospitalizations and the use of the ER, that tries to keep people out of nursing homes if possible, and that creates a system that is person-centered and person-directed. That's what integration means. And unfortunately, I think, for many of us, the world of elderly services has often either been dominated by the medical system or it has been bifurcated into the social and medical care. And the truth is they need to be integrated together. And we have finally figured that out after years of screwing up in the United States. So that if you look at where our resources are going these days, and this is really because the evidence shows that if you invest in good housing, good social services, early prevention like Tai Chi and exercise, that you actually can make a difference in helping people remain in their communities for much longer, and you also avoid more expensive care. So you achieve what we call in the US the triple aim, which is good health, quality, at an efficient cost. And those are something that everybody ought to be interested in, all of us, at the individual, at the community, at the societal level, at the governmental level. So I just wanted to tell you a little bit about what we're doing in congregate housing, and I know you don't have similar, you may not have public housing in the same way that we do have in the United States, but I would argue that wherever you have large numbers of elders living in community, and we call this a naturally occurring retirement community, I think that may be a similar concept here, there is the potential to actually bring together services and supports and to help people remain in their communities for as long as possible. We are now involved in a randomized controlled trial in 40 sites around the country where we are bringing in a social work nurse team that works with folks living in apartments and in communities and follows them over time and works to make sure that early prevention is in place, that mid-risk is managed through good medication management, good mental health services, and that we begin to make sure that folks do not unnecessarily go into the hospital and go into the ER. And our early effects of this randomized controlled trial are actually finding that we are not only achieving those goals, but we're saving costs to our Medicare program, which is our big health insurance program for the elderly. So you can do it all if you put these kinds of things into place. Again, we're reducing the growth in Medicare spending. We're seeing signs that we're reducing nursing home placement. We're reducing hospitalization and ER use. We're improving the quality of life of these folks who live in these communities. We're retaining the quality of housing. And we're mitigating social isolation. And I know you're going to have a session on social isolation here later today. But social isolation is the sleeper issue for older adults. And what we have to do is figure out ways that we can address that. And I will tell you that bringing a community approach to linking services and supports is a way to really deal with social isolation. So finally, I just want to talk a little bit about the translating to policy and practice. Now we have our federal health and housing agencies working together. That has never happened before in the United States. We have an adoption of a service-enriched housing program in the state of Massachusetts and in some of our health plans around the country. We had the adaptation of this model into naturally occurring retirement communities throughout the United States, and we're looking at this in market rate communities as well. So the lessons learned from all of this is that, number one, it is really, really difficult. After 40 years, I'm still looking at a lot of the same issues that I looked at 40 years ago. Integration of services and supports is not a new concept. It's been around forever. Language, goals, and time frames of stakeholders often are very difficult. How many of your medical people speak to your social services people, speak to your housing people, and use the same language. You got to figure out how you translate across these sectors. Multifactorial qualitative and quantitative research is most effective. I don't know how many researchers we have in the room, but we got to begin to bring those things together in spades. Collaborations from the start are optimal. If you think you're going to bring the community in later, forget about it. It's got to happen from the start. And by the way, the older adult has to be in the middle. Every single one of our programs starts by asking the older adult what she needs. If it's not going to meet her goal, it's not going to meet anybody's goal. Often we're looking at old wine in new bottles. So if you think you've got a new idea, you probably don't. And that's okay, because you have to keep reinventing these ideas over and over and over again. As I tell people, you know, a pencil and a piece of paper is a technology. It's called writing. It was one of our early forms of communication. And we're always reinventing, but the concepts are the same. And finally, I would say that learning from our mistakes is as important as learning from our successes. If we had done anything different in the US, we would have never started with a nursing home industry. And one thing that you did a heck of a lot better than we have is at least you have had a long history of home care. And it may not be a perfect system, but for us, we have spent the past 20 years getting out of the institutional bias that our environment set because our policies put us in the wrong direction 50, 60 years ago. So learning from our mistakes is really important. And with that, and I don't know, Yossi, if we have any questions, but
אנחנו ניקח שתי שאלות כי אין הרבה זמן. באנגלית בבקשה, חני.
שנייה, בואו תעבירו. Help increase quality of life of residents and the people who are getting care by increasing the quality of life of the workers. So I really connected to the better jobs, better care part of what you were speaking about. The whole thing was inspiring, actually, so thank you. And I want to know if you know of research that talks about curriculum and content to reach the non-professional caregivers and how best to serve them while also serving their institutions that hire us to come in.
Sure. I think I'm understanding it. Sometimes the nomenclature in different countries is different. So our frontline workers are really what we used to call non-professional workers. The first thing we have done before we even get to the curriculum part is we never use the word non-professional again. In fact, I mean, our organization spent a year working on competencies for home care aides, personal care workers, as well as nursing assistants in nursing homes. The competencies were about 18 pages long. If you think that's a non-professional, then you're looking at the wrong business. These are professional jobs that need to be professionalized, which means that the curricula needs to be invested in, needs to be targeted to the complexity of the job, and then needs to be tested and monitored over time. We have some fabulous examples of curricula. The best probably in the United States is in Washington State. We have an entire statewide curriculum where frontline personal care and home care workers are trained as professionals in very complex jobs, and then they have a series of career ladders and lattices. And I can certainly share those with you. But I think that everybody needs to understand that we are not going to get anywhere in aging services without an investment in our workforce. It's like saying you're going to create quality by putting an electronic health record in your organization. A database provides you with nothing other than the ability to share information. Most of the work that gets done in our organizations gets done by frontline. And you will not have magical quality. You will only have quality if you invest in a curriculum, and I would argue that you need to have good orientation training, and you have to have really good in-service training, because the jobs are changing all the time. But never from your lips should we say non-professional again. The other thing that I never say is low-wage worker, because when you say low-wage worker, you have institutionalized the concept. So professionalizing the field, I think, is really what is essential. I don't know whether anybody else has any.
I thank you very much for wonderfully inspiring words. You made a point, excuse me, you made a point about the necessity of supervising the aides. And that's a very difficult but real issue.
It is.
Because I don't know in the country here how to get such a thing going. I come in as a psychologist, visiting people in their homes, wherever they are. They may have foreign workers as aides. Sometimes there's a language difficulty where the caregiver and the person who needs him don't even understand each other properly because they have different languages. I may serve as an interpreter sometimes to the two of them, but I found it so important to have somebody supervising.
It is.
The children don't live close by. There's
Right.
no official supervising person there, and it's necessary. Thank you very much.
It is extremely important, and it is extremely difficult. And, you know, because in the United States, we have a lot of the same issues. I mean, it is not unusual for us to have 25 different languages being spoken for aides who are going out in the community or who are in our nursing homes as well. Because of that, and I don't think we have it completely right, but we have good examples of very culturally competent training and support for the people who are actually managing folks who go out into the community. And the concept, as a psychologist, you will know that what we're talking about when we talk about supervisors is not a command and control model. This is a nurturing support role. The other thing that has been extremely effective in aides going out into the community is the development of peer mentoring programs. So this is aides helping other aides to actually do things right. And we have created matching programs where we actually have aides who connect with each other. They may have to connect via a phone. They may need to connect virtually, but they are connecting. And in essence, we are building community for this workforce. It is extremely difficult. On the other hand, this is the future of our service system. In the United States, the home care aide job is the fastest growing job in the US. And I would imagine that you have that here as well. Think about the potential for this as job creation in communities across Israel or across the US if we do this right. And the languages are a serious problem, but you know what? They are not necessarily a barrier. I mean, we have found that communication works even if you don't speak the same language. And in essence, I would argue that trying to make everybody speak Hebrew is not going to make a whole lot of sense. They tried that in Japan, and they are failing miserably. It is better to figure out how people connect with their body language, with the way that they touch each other. You know, an aide gets it, and so does an older person. They know each other, and those relationships are essential. But the aides need good supervision. And however we figure out how to do that, we need to do it well. Am I ready to go? Yeah. I'm sorry, but I'm going to be here all day, so thank you all so much for letting me do this.